Hello and welcome back to Advanced Gross Human Anatomy, and today we will be dealing with the dissection of the heart. So in our previous dissections we looked at the lungs and we removed them from the thoracic cavity, and we were left with the mediastinum, which is where the heart will be. So if we look within the mediastinum underneath the fibrous pericardium, you'll find the heart. This is just an interesting shot here of inside one of the ventricles, probably the right ventricle. Here you can see the papillary muscles. We'll see this in a little bit with more detail. The chordae tendineae coming off of those papillary muscles as they attach to the atrioventricular valves, which will ultimately prevent the flow of blood back up into the atria. And the papillary muscles arise from the wall of the ventricle. You can see the walled portion here. The Greeks had a funny name for this. They call it trabecula carne. Trabecula means branching. Carne means meat. Apparently it looks like branching meat to somebody. So that's what we still call that. So just an interesting, cool shot of that. But today we will be dealing with removing the heart. So to do this, we'll need to cut the connections that hold the heart in place. First thing we'll do is within the mediastinum, it's still contained within the pericardium here. So what we'll do is cut straight down the middle of the pericardium. Okay, and then cut kind of these go laterally then on the top and the bottom to make little doors that you can kind of fold open the pericardium to expose the heart itself. Next, you'll find the superior vena cava entering the right atrium here. And you'll also find the inferior vena cava. You'll see this if you lift up this bottom margin of the heart as it sits on the diaphragm. You'll see the inferior vena cava punching right through the diaphragm and entering almost immediately into the right atrium. So you'll be able to see that. And you'll need to cut both of these vessels here and underneath. Maybe a better shot if I show you this one. Now that the heart, this picture obviously is just showing the heart outside of the body. So first thing we'll do is cut the superior vena cava, okay, before it enters into the right atrium. And then again, kind of lifting the heart off of the margin of the diaphragm and cutting the inferior vena cava. Okay, and you'll see that where it punches right through the diaphragm to enter. Okay, and then next you'll need to cut the aorta. Okay, try to cut that before the arch of the aorta. We'll learn all these vessels later on here, but when we talk about the head and the neck. But if we can cut kind of right through here, cutting the aorta before the arch. And then next you're going to cut the pulmonary trunk. Okay, as it leaves the right ventricle, blood will pump through the pulmonary trunk. So you can cut that again before the split of the pulmonary arteries, the left and the right. You can see going underneath the arch of the aorta, behind the superior vena cava. Here's that right pulmonary artery. So we're going to cut this pulmonary trunk before those. Okay. So you'll have that done, and at that point you'll feel like, boy, I cut the superior and inferior vena cava, I cut the arch or the aorta before the arch, I cut the pulmonary trunk. Boy, this thing should pop right out, but it doesn't. Actually, the tricky part is yet to be done. What's holding the heart in place, and rather strongly, in fact, is the pulmonary veins. You can see them entering back here. Coming into the left atrium. So if we flip the heart around, you'll see these four holes here on the left and the right pulmonary veins, bringing oxygenated blood back to the left atrium. But what's tricky about this is that it's behind the heart. So you'll need to cut these a bit blind. So this is really the hardest part of removing the heart, is cutting these pulmonary veins as they come back into the left atrium. I hope I said that correctly. Pulmonary veins coming back into the left atrium, pulmonary arteries leaving the pulmonary trunk going to the lungs. Remember that circulation is reversed. in its naming. Okay, so here's the thing though. You want to try to cut that without cutting off the left atrium. You want to be able to cut these pulmonary veins before they enter the left atrium. But it's going to be, they're holding it quite tight to the back of the pericardium. So it's going to make it a little bit more tricky. So make sure, our rule here is that the one holding the scalpel is the one doing the cutting. So make sure that you're not holding something out of the way, expecting someone else to miss your finger. So if you're the one holding the cutting device, you are the one that should be holding this and identifying where these structures are with your hands prior to cutting them. Okay, so once you get that out though, once you cut the right pulmonary veins and the left pulmonary veins from right before they enter the left atrium, the heart should be free now to come out of the body. Okay, so what you'll see here, let's go to this picture here. What you'll see once the heart is removed is a couple of interesting things. You'll see first the arch of the aorta. This is actually quite large. People talk about this as the descending aorta or the thoracic aorta. As it comes down from the arch, it'll first split into the brachiocephalic artery here, the trunk, then it will go up into the left common carotid, left subclavian. Again, we'll learn those later on, but those will still be attached up into the neck since you cut it before the arch of the aorta. As it wraps around though, then it comes down. It's almost the size though of a garden hose. It's actually, people are shocked sometimes to see how large this structure can be. It sits just to the left of the vertebrae, the aorta does. And you'll also see on the pictures here, and you'll see it on the bodies that you'll dissect too, the vagus nerve as it comes down. So you can see how it comes down over, on the left side, it comes over the arch of the aorta. On the right side, it just comes over the subclavian artery. And then it's going to come down. And we talked last time about how that will branch then into the cardiac, esophageal, and bronchial plexuses, along with branches from the sympathetic trunk to form the autonomic innervation to those structures. So we talked about that last time. But what's interesting, on the right side, this comes over the subclavian artery, the vagus nerve does, and then loops underneath it, and then becomes, as it continues up, it will go more anteriorly, and it will reverse. It will become the recurrent laryngeal nerve, or the ascending laryngeal nerve, sometimes called, on the right side as it comes around the right subclavian artery, and then back up towards the larynx, the voice box. On the left side, it's going to do something similar, but it's going to be a little longer. It's going to go all the way down and then loop around the arch of the aorta before it comes back, and it's behind it at this point. And here it is peeking through. You can see that recurrent or ascending laryngeal nerve coming back up. So the vagus nerve, as it hooks around, will ascend back up toward the larynx and become the recurrent or the ascending laryngeal nerves. So that's just something interesting to see there. So now that we have the heart out and we've seen kind of what's behind the mediastinum behind it, let's take a look at now some dissections. How are we going to dissect this thing? So the first thing we'll start with is making a cut straight down from the pulmonary trunk. We're going to cut right from the pulmonary trunk straight down through the right ventricle. Now it's important here to try to avoid going into the anterior interventricular sulcus, where there's this artery and vein. We'll see those in a little bit more with more detail. You want to go straight down through. You want to also avoid cutting more laterally into the right coronary sulcus, so as not to cut that right coronary artery through here. We want to go right from the pulmonary trunk almost straight down toward the margin where the heart used to lay onto the diaphragm. Okay. Now, once you open up this ventricle, you'll want to clean out some of that old blood. Blood, as it gets in contact with the fixative solution, the formaldehyde and so forth, when the bodies were fixed, it starts to harden, and it will almost take on the consistency of like dried paint almost. It's kind of clumpy, and you'll kind of you'll take a blunt probe and you'll bring it over to the sink. We use a colander at the sink and use some warm water to kind of soften up that blood and start to kind of clean out the contents of this right ventricle. Okay. The next cut you'll do will be into the right atrium here. So you're going to go basically from from the superior vena cava straight down to the inferior vena cava, just straight down through, and that's going to open up the right atrium. And the same thing, you'll just clean that, the auricle, here you can see this kind of ear-shaped portion of the atrium. You'll clean that auricle and the atrium out just like you did the ventricle, cleaning out that dry blood. Well, it's kind of fixed blood. It's just kind of coagulates. It's hardened up. So you'll clean that out. And then you'll look for, once you get that out, let's see if I can find a good shot here of the AV valve here. So here's kind of a cut from the superior vena cava down to the inferior vena cava. As you open this up, you'll kind of see the atrioventricular valve here as it enters from the atria into the right atria to the right ventricle. Okay. So let's see here. What else do we want to notice? Okay, so once you do that, you can also come, go back to this shot here, you can come over here and make a cut on the other side of this interventricular sulcus on the anterior side. You're going to cut straight, you're going to cut on the outside of that, about here, cutting down the outside of the left ventricle. Okay, so being sure again not to cut through that anterior interventricular sulcus, but you'll cut kind of from the top of that down laterally to expose the left ventricle. Next, on the back side of the heart, if I can find a good shot here again of that, you'll want to basically cut open the left atrium. If you can find those pulmonary veins that you cut off to remove the heart, if you can just make a cut straight through the left atrium, kind of a horizontal cut here, right through both of, kind of between the pulmonary veins, you'll be able to open up and notice that left atrium there too. Okay, so that's just how we're going to open that up. And again, using a colander with some warm water in the sink, just to loosen up all that blood, that blood. If you can get rid of some of that dried blood and see the structures, that's going to make your life a lot easier here. Okay, a couple things just to note here. One thing we're going to see on the heart, if you look back at the pulmonary trunk, back in the body now, with the heart you've removed, you've cut off the pulmonary trunk here and the arch of the aorta here, prior to the arch rather, the aorta. And what you'll notice between them is this ligamentum arteriosum. So between the pulmonary trunk and the arch of the aorta. Now in the womb, this was a vessel or a tube. Because the lungs were full of fluid in the womb and blood isn't getting oxygenated there, this was a bit of a bypass, so blood could go from the right ventricle out the pulmonary trunk, and instead of going through the pulmonary arteries to the lungs for oxygenation, it could just kind of bypass that and go right into the aorta to be introduced into the systemic circulation. But you know, some blood did actually go through then in the womb toward the through the pulmonary arteries toward the lungs, but just enough to support the lung tissue itself, just to give it some nutrition, because the oxygenation was actually happening in the placenta. So any blood from the placenta went through the heart rather than sending it all to the lungs. You've got a couple of bypass systems. So the ligamentum arteriosum, it used to be in the womb, this was called the ductus arteriosus because it was a patent opening in the fetus. But at birth, this will contract down and lose its lumen and become what you see here, the ligamentum arteriosum. Okay. You should still be able to see within the body, within the cavity here, I go back to here, you should still be able to see the brachiocephalic trunk splitting into the right and left pulmonary arteries. So you can, well, that's not a great shot of it here. You should be able to kind of still see that the trunk splitting into the left and right pulmonary arteries. You should be able to see the inferior vena cava. There should be a hole in the diaphragm where you cut that as it entered into the right atrium, as it will coming from the abdominal cavity. And the superior vena cava should still be attached, being held up by the right and the left brachiocephalic veins. Again, we'll see those later on when we talk about the neck. So those brachiocephalic veins would flow into the superior vena cava, and that's what you cut as it entered into the right atrium. Okay, so as you're looking at the heart, we'll just keep this shot up here. You'll see a couple of things here. You'll see a coronary sulcus. Now this is a ridge that goes on the top portion of the heart. It goes all the way around the heart. You can kind of see on the left side here and the right side here. If I bring it to the back side, you'll be able to kind of see here and here that coronary sulcus on the right, and then the left as it wraps around back toward the front. Coronary comes from the root which means crown. That's the same root we use for words like coronation, the crowning of a new royalty. But again, it goes all the way around, and it contains the coronary arteries are found within this coronary sinus. Now, what's interesting about the coronary arteries is they will come off immediately. They'll arise immediately off of the aorta. We'll see in a little bit as the left ventricle pumps, it goes through the aortic semilunar valve, and immediately on the other side of that valve are the exits of blood for the right coronary artery and the left coronary artery as it comes around. So we'll be able to see that in a little bit as we see a different shot of that. Let's see, what else do I want to say there? You'll also see the anterior interventricular sulcus right through here. This is what you tried to avoid when you cut from the pulmonary trunk straight down, and from just outside of that to cut into the left ventricle. So to open up the ventricles, you want to cut on either side of the anterior interventricular sulcus, which also contains a coronary artery, which we'll see in a little bit. And the posterior, you can see on the back side, posterior interventricular sulcus. So between the ventricles, you'll see another sulcus here that also contains another coronary artery. So let's look back at these coronary arteries for a bit and see the right coronary artery coming off of just distal to that aortic semilunar valve. In the aorta, the first branches here are going to be this right coronary artery. Now, to dissect into this, you'll need to take a blunt probe and kind of dissect some of the fatty tissue around this. You might be shocked at how much fat is around the heart. It's actually quite shocking sometimes. So depending on the hearts that you have, you might need to do quite a little dissection kind of around this coronary sulcus through here. So coming off of the aorta, right at the aortic semilunar valve, it wraps around this the right side and the right coronary sulcus, and it gives some branches here. The first branch, the big branch you'll see, is called the marginal branch, and that kind of is named that because it sits right on the margin of the heart as it lays on the diaphragm, right through here. So this marginal artery is a branch off of the right coronary artery here. And then it continues around the back side. It loops around the back of the heart. Bring this picture back here. So the right side here. And it will become the posterior interventricular artery. So the one that's in the posterior interventricular sulcus is the posterior interventricular artery, named for where it is. But it's typically a branch off of the right coronary arteries that loops around. There is a portion of the population where that it does come from the left coronary artery in a certain percentage of the population, but it's a small percentage. Typically, it's off of the right coronary artery that you'll see that. The next thing you'll see is the left pulmonary artery. Now this is a little bit tricky because it's coming off of the arch of the aorta, again, right past that semilunar valve, and it comes behind the pulmonary trunk. So since you cut that off, you can kind of tease that behind. You'll take a blunt probe and pull that away towards you, and you should be able to kind of sneak back and see where that left coronary artery arises off of the aorta again, comes behind the pulmonary trunk. Here's that auricle of the left atria as it kind of wraps around the back side of the heart and becomes that left coronary artery. Now right here it stops. It kind of stops there and it continues down. So as you kind of right past where you push that pulmonary trunk away to see it, that's where the left coronary artery stops and changes its name. The big branch coming straight down here is the anterior interventricular artery. So we saw a posterior interventricular artery, which is the continuation of the right coronary artery in the backside. The anterior side is going to be directly off of the left coronary artery. This one has a couple other names. It's also called the left anterior descending artery as it comes down. And that's you could also name it that. It supplies the left ventricle. This is an important one. If this one gets blocked or occluded, oftentimes the vernacular for this, as it gets occluded in a heart attack, would be the widowmaker, because it does supply, it's a major supply vessel for the left ventricle, which supplies much of the systemic circulation. Now the other branch here, right at that split, so the left coronary artery behind the pulmonary trunk, right when it splits and bifurcates down into the left anterior descending or the anterior interventricular, it will come around. This is called the circumflex artery. It comes around the back side. You can see it here coming around the back side of the heart as it comes back and around. Circumflex artery. Circum means around, and flex means to bend, so it bends around. It kind of comes around the back of the heart. Okay, so those are kind of the big ones there. There are other atrial branches that come off of the right coronary artery. There's a couple big ones called the superior cable branch. Sometimes goes up and towards the superior vena cava. There's also nodal branches that go toward the sinus node within the left atrium or the right atrium, and these can occlude over time. These smaller ones going towards the nodal arteries can occlude over time, which can cause a loss of normal sinus rhythm, possibly leading towards eventual atrial fibrillation, the need for a pacemaker, possibly. When you're looking at the bodies that you see, a lot of the bodies we have are aging. They're quite old, and so they may be losing those nodal arteries, may be losing some of their integrity and be difficult to find. So we don't need to find those during this dissection. The ones I'm really interested in, again, coronary artery, right coronary artery, left coronary artery behind the pulmonary trunk, the marginal branch, marginal artery, and then the posterior interventricular artery on the backside, and then the anterior interventricular artery and the circumflex coming around. Those are the big ones. That's the arterial supply. When we look at the venous return, you can see some of the veins coming down into the heart musculature here within, kind of accompanying many of those arteries. Often have the same name, but when we're talking about the veins, they're a little bit different. So we talked about the coronary arteries. The veins we're going to call cardiac veins. So it's a little bit different. Coronary for arteries, cardiac for veins. Just keep that in mind when we talk about these. So they're named like the arteries, but not really. So all the cardiac veins, let's start with the big one in the back here. All the cardiac veins come in to what's called the coronary sinus. Okay, so they all flow into this coronary sinus before they will then enter back into the heart. It lays on the back of the heart, kind of right in that posterior cardiac sulcus, the backside of the coronary sulcus, before it flows back into the right atrium, right kind of where the inferior vena cava was going to come in. It's located, like I said, back in the posterior coronary sulcus. Now it's big. It's like the size of maybe your pinky or a big pencil. It's quite large. You'll be able to kind of see that pretty easily. Now, there are the tributaries that enter into the coronary sulcus. Let's go back to this picture here on the front. There's a couple big ones here. The big one right in the front here, along with that the left anterior descending or the anterior interventricular, this big vein draining now the left ventricle, coming back and around. We'll call that the great cardiac vein. Okay, found within the anterior interventricular sulcus, along with the left anterior descending artery. Okay, now the one on the marginal artery here, this vein draining the right ventricle is going to be, along with the marginal artery, is going to be the small cardiac vein. Okay, found on this side. So the great cardiac vein and the small cardiac vein. Now, the middle cardiac vein is found in the posterior interventricular septum, right back here. Now, you might think, this seems funny. Why is it great, small, and middle? If we go back to this picture, though, with a scan called an angiogram, looking at it from the front, which is using a dye to be able to see the vessels. It kind of makes it look transparent with the heart, but then you're able to kind of notice the vasculature. So when you see this, the big one on the front is the great. There's a smaller one on the outside here on the right side, the small. And then if you can see through this, imagine with an angiogram being able to see through this heart, you'd see that posterior interventricular artery right about here. It's in the middle of the great and small. So that's why they call it the middle cardiac vein. And that's the venous return that will all flow, again, back into this cardiac sinus, which is one of the three pipes entering the right atrium. So you got the superior vena cava, inferior vena cava, and right next to inferior vena cava is the the coronary sinus, which are the three vessels entering the right atrium, and then it just starts the process over again. So for revascularization. Okay, let's take a better look now at the right atrium. You can see here the heart back in the body with the pericardium kind of cut around it here. You can see this atrium here. You'll see this, it almost has this ear flap on there. And that's what the Greek called this. They called it the auricle, which is a word for ear, which used to be the original atrium within the heart, within the womb, was the original atrium. The auricle was more muscular. So when people opened it up, it looked like, well, here, let's open it up here. Here's just the right atrium. When you opened it up, it had a lot of musculature in the wall here. And so initially, the atrium was doing more of the work to pump the blood in development in utero. So as the ventricle grew, they ended up taking on more of that contraction responsibility, leaving the atria eventually to be more smooth-walled. So you'll see in the auricle, kind of that original, pump, the original atrium in utero has much greater walled. It's got much more muscular walls here. These are called pectinate muscles. Greeks thought this looked like the teeth of a comb. That's what that means, pectinate, like teeth of a comb here. So mostly within the auricle, but the rest, as the ventricles developed, then the rest of this atria started to develop greater, but it didn't need to be as muscular. So you can see it's much more smooth walled on the top here, and then that entrance into the valve here, entering into the right ventricle. Now, you'd also be able to notice here, you won't be able to see this on our labs here today. This is more of a histological dissection here. You'd need to take some slides, but you could see the SA node kind of located more high in that interatrial wall. And then the AV node located a little bit closer, more down here toward the atrioventricular valve. But again, don't look for those today. We're not going to find those within this dissection. You'd have to do more of a histological examination of the tissue to identify those structures. Now, in this picture, what you're also going to see here is an interesting structure. This is another bypass system for in utero. This depression called the fossa ovalis. This in utero used to be called the foramen ovale. And that closed upon birth here. But remember, with the blood supply not needing to go into directly, you didn't need to pump all that blood from the right atrium into the right ventricle, out the pulmonary trunk, out the pulmonary arteries toward the lungs for oxygenation. You could just bypass that. So this was a way for the blood to go from the right atrium to directly over to the left atrium, and then down into the left ventricle to pump out the aorta to the body. So when that is no longer needed after birth, that closes up and becomes the fossa ovale. So it's more of just now a depression. It's a thinner portion of that interatrial septum here between the right and the left atria. So what you don't want is for that to stay open later in life. And, I've heard varying numbers here, 13, I've heard up to 22% of people have a patent foramen ovale. And that's a condition that's going to limit their ability to endure, strenuous activity or stress. They might get out of breath more frequently, just lack of oxygenated blood getting to the tissues. Because again, if blood is bypassing the lungs and going right to the left side, right to the left, that might have been confusing. If it's going directly to the left side of the heart from the right side, it's going to bypass the lungs and you're not going to get that oxygenation. You're going to still be pumping deoxygenated blood to the rest of the body. So that can be an issue. Also an issue, if that stays open, the risk of clots. Small clots anyway, can kind of make their way down from the right atrium into the right ventricle, out the pulmonary trunk, out the pulmonary arteries to the lungs, where they'll kind of get filtered out. Obviously, big clots, pulmonary embolisms are a bad thing in many ways, but the smaller ones can often kind of get filtered out that way. But if they're bypassing that system of the lungs and going right to there I said it again, directly to the left atrium, now down into the left ventricle, out the arch of the aorta. Now they could actually go into the small vessels of the brain. You could have infarction or stroke. Can happen quite easily with an open fossa ovale. Okay, ovalis, foramen ovale, fossa ovalis is kind of that naming. Okay, now let's move on to talk about the right ventricle. Now, this picture might be a little funny. I think it's a great picture, but it looks a little bit weird if you don't know what you're looking at. Netter here has drawn this in a way to cut. He's cut the heart open in a trend, kind of a section. You can see where this plate is cutting through, and he's opened it up like a book. So you can see the right atrium, the right ventricle, interventricular septum, left ventricle, left atria. But if you open it up here's the left atria, left ventricle, interventricular septum, right ventricle, right atria. Fold this back out over this, and it will kind of opens like a book. So you can see right, right, left, left, just to get your orientation. I think that's important. So again, blood is coming from that right atrium through this superior vena cava, inferior vena cava, can't see that here, the coronary sinus entering into the right atrium, deoxygenated blood back to the heart. It's going to go from there into the right ventricle, but it's got to go through the right atrioventricular valve. Okay, so it's going to go through that space down into the right ventricle. Now, attached to the right the atrioventricular valve are those chordae tendineae. Again, if we can go back to that previous slide, actually, I think that's just neat. Let's go back here for a second. Here's these chordae tendineae, an actual photograph of this. The chordae tendineae attaching themselves to the valves here. They're coming from the papillary muscles, which are branching off of that trabecular carne. Let's go back down to that other shot here. So here you can see that when the ventricle contracts, when this ventricle, that musculature of the wall contracts, it's going to tighten up those papillary muscles, which are going to pull on the chordae tendineae and not allow then, they're going to be able to shut the flaps here of that atrioventricular valve, but not allow it to get blown back up into the right atrium. So they kind of hold it shut, not letting blood go back up into where it once came from. So the papillary muscles are going to rise from the trabecular carne, and then they will contract as the ventricle contracts, and then push the blood out the pulmonary trunk. Now, it's not so easy to see this here. Probably easier to see this shot here. So the right atrium, this is probably a better picture for this anyway. So you can see the papillary muscles here, chordae tendineae attaching to that tricuspid valve. There's 3 flaps here. Actually, most of the valves, three of the valves have 3 cusps. Only one of them has 2. We'll talk about that on the left side. But this atrioventricular, the right atrioventricular valve, coming here from the right atrium into the left, or into the right ventricle. Again, ventricle contracts, pumps blood out the pulmonary trunk through the pulmonary semilunar valves here, and then pushes it out into toward the lungs, toward the pulmonary arteries. But then as it contracts, it's going to hold these valves from getting thrown back up into the atria. You can imagine a forceful contraction. If you didn't have something holding those valves down, those papillary muscles, or with the chordae tendineae holding them down, they're just going to push straight back up in and let blood back up into the atria. So this is kind of enforcing a one-way flow with that contraction. So once it pumps out the pulmonary semilunar valves, these are just basically like big cups. They just kind of sit and they fold up together. And so when the ventricle is relaxed and the AV valve is open, the right atrioventricular valve is open, allowing blood to come from the right atrium into the right ventricle, these close. But when blood pumps out, when the ventricle contracts, the chordae tendineae hold this shut so that the blood can't go back up into the atrium, but then it pushes it out. And you can see the shapes of these. It would allow, think of like a door. If you were just to push through here, you could push up into this, and they would open easily, pushing that blood into the pulmonary trunk. But then when that ventricle relaxed, the flow of blood coming back down into it would cause these cups to fall down together, and they kind of attach themselves right next to each other, and they hold it, they sling it shut. So again, it's like ensuring a one-way valve here, not allowing blood back into the ventricle once it's pumped into the pulmonary trunk. Okay, you can see the right atria here. Let me see. You can see it here, maybe a little bit better. Again, it's kind of around the back side of the heart. Okay, the right atria is more on the front. The left atria is more on the back side. It receives blood from those 4 pulmonary veins from the lungs, so oxygenated blood back into the left side of the heart, and blood's going to go through the AV valve here in a second, the left AV valve. But let's just keep on this side for a second. But you can see the auricle pushes way back to the back side. So it's just, I don't know, I just wanted to show that again, it's on the back side. So remember when you were cutting here, those pulmonary veins, you were doing it kind of blind, okay? So let's go back to this shot and see the left atrium. And now here, this atrioventricular valve on the left side is called the mitral valve. Okay, it's going to have 2 cusps. You could call it the bicuspid valve because it only has 2 cusps versus the tricuspid, which has 3. Or you can call it, another name for it is often called the mitral valve. Now this is funny because it's got 2 cusps here, right, versus the 3 on the right side, but it's under a tremendous amount of more force. So it often needs attention and possibly replacement as it weakens because it is pushing through a greater pressure. It's going through the systemic circulation out the aorta versus the right ventricle just going through the pulmonary circuit for blood flow, which is pretty much right within the thoracic cavity. It doesn't have to go very far. But that mitral valve, again, same instruction here, same kind of orientation with the papillary muscles arising off of the trabecular carne, chordae tendineae holding that mitral valve or the bicuspid valve or the left atrioventricular valve shut as the left ventricle contracts, forcing the blood then through the aortic semilunar valve. So same kind of structure that you found with the right ventricle going through the pulmonary semilunar valve. This is going to go behind that now into the, behind that into the aortic semilunar valve. So you can see here on this shot too, nice dissection of the myocardium. You'll be able to see this in your dissection today as well. That myocardium on the right side is much thinner. And you'll see it here on the left side much thicker, right? So it has to pump through the systemic circulation on the left side versus just the pulmonary circulation on the right. So the differences there are depicted with the size of that musculature. So again, pumping out then the aortic semilunar valve into the aorta as it comes towards the rest of the body. You can see here this interventricular septum is interesting here because it's much thicker, it's much more muscular at the inferior portion and more membranous, like you can see here kind of on this slide. It just goes right, it's more of a membrane on the top portion between the superior portion of those ventricles. That's often a defect seen in kids, a common defect, a membranous ventricular septal defect is what that's called in kids. So when this kind of creates an opening here, can be common where blood will kind of oxygenated blood and oxygenated blood over on the left side and deoxygenated blood on the right side. Oop, I got that wrong, didn't I? Oxygenated blood on the left side, because this is left and left. Well, let's go to this side. Oxygenated blood will mix with deoxygenated blood, and that can be tough with newborns. Now, what you'll notice if that happens is that the baby is born healthy. Because remember, in utero, that's okay. You don't need, because you're not oxygenating your tissues from the lungs. You're getting that from the placenta. But if that septal defect, if that membranous septum isn't fully shut, after the child is born, you'll see that they'll struggle to develop. So they're born healthy, but then they struggle to develop because they're not getting that oxygenation to the rest of the blood, because you're getting kind of a common chamber of the ventricle. This is just another interesting shot here too. Again, you can see immediately off of the right of the aortic semilunar valve as it pumps out the left ventricle, out those chordae tendineae again are going to close up that bicuspid valve, not allowing blood back into the left atrium. The left ventricle contracts and it pushes out the aortic semilunar valve into the aorta, and then it will arch around, coming down into the descending aorta, into the abdominal cavity. But right immediately outside of those cusps here, you'll see the openings for the right and the left coronary arteries as they come around here. So the right and the left coronary arteries leaving, then going into that coronary sulcus, and we've talked about that circulation already. Okay, how we doing? Good, good. Here's another just interesting shot here, looking straight down. Here you can see the valves open. Here you can see the anterior and the posterior, the right and the left, anterior, posterior, right, left. So here you can see the atrioventricular valves are shut here. Right here you can see they are open, rather. The right atrioventricular valve is open, left atrioventricular valve is open, and here you can see the aortic semilunar valve and the pulmonary semilunar valves are closed. Okay, so you can see the tricuspid valves all the way through, except for the mitral valve right here on the left side. Here now you can see as the here's those chordae tendineae attaching to the papillary muscles right down there. As the ventricle contracts, though, here's ventricle relaxation, atrial contraction, pushing that blood down into the ventricle. As the ventricle contracts, it's going to come out the aortic semilunar valve. Blood's going to come out the pulmonary semilunar valve from the right side, aortic from the left. And then those chordae tendineae, you can see how there's like these balloons there. It's like they're pushing, that blood is forcing back, all wanting to go back into that right atria and left atria, but those chordae tendineae are holding those valves shut, not letting blood out back from where it came from, but rather continuing its circuitry back to the next, through the aorta and through the pulmonary valve. Kind of a cool shot there. Okay, a couple of pathologies here. Last thing we'll talk about is just some common pathologies within the heart. Blockage of the coronary arteries here. So we talked about the right coronary artery and the left coronary artery within the sulcus. As plaque builds up, this can happen and cause a reduction of circulation to the heart musculature itself, and that's not a good thing either. So this can be making it difficult for the heart to accept challenges during exercise or various types of stress, like taking classes like this. So if you have blockage here, your heart isn't going to be receiving the nutrition that it needs. When that happens, you could have what's called a myocardial infarction. Myocardium is just the heart muscle itself. Infarction is death of that musculature. So myocardial infarction, cell death within the muscle. Also called a coronary or coronary occlusion, another name for that, or a heart attack is kind of the common vernacular for I had a heart attack or an MI, myocardial infarction, or just sometimes a coronary, meaning a coronary occlusion. So a couple things they can do is one thing they can do is put a stent placement here. They could thread a catheter up from your groin and your femoral artery, weaving their way through your circulation back up eventually into the heart, and then there's this balloon that can get pushed out, and then with a mesh stent here that will place that stent, kind of pushing it, smashing it against those plaques, going right into that plaqued area where it was blocked, and then inflating this balloon to push that plaque further away towards the wall. And then this mesh, often lined with medication to keep the blood from clotting next to it, will stay in place, kind of encouraging that lumen of that vessel to stay patent or open, and then the balloon gets deflated, and then they take that catheter out. So if you've heard of somebody getting a stent placed, that's what that would be. Another way they can do this is with bypass surgeries. So the bypass surgery is literally where they're going to take an artery, and they're going to graft or harvest another artery from your body. Often it's the radial artery in your arm, or the internal thoracic artery, which we saw on the anterior side of the thoracic cage. They'll take those good arteries and take them out. They'll cut them out, and your body does a nice job of finding other ways to get nutrition to where they were supplying blood flow, and then they'll sew them onto the aorta right here, and then go down distal to the blockage. So if the blockage was in the right coronary artery here, they would just bypass that by taking good oxygenated blood off of the aorta, distal to where the right coronary artery came from initially, and then bypassing that toward distal to the occlusion. Here's one coming distal to, if the left anterior descending or anterior interventricular artery was occluded here, for instance, they could bypass that by coming off of the aorta and then coming down distal to that occlusion. So if you've had one bypass surgery, it's just a bypass. If you've had two, it's a double bypass. 3, triple bypass. And boy, if you've got all four, if you've got right, left, marginal or circumflex or posterior interventricular, you can have a quadruple bypass. Just named by the number of arteries that you're bypassing. Okay, that's probably enough for this. I hope you learned something, and I will look forward to seeing you in lab.